Welcome to the Advancing the Kingdom podcast. We're streaming live on all social media platforms and podcast streaming channels. Get ready for a revelatory teaching from our apostle, Matthew Tillery.
Well, praise the Lord. Praise the Lord. Thank you so much for tuning in to the Advancing the Kingdom podcast. I am your host tonight, Matt Tillery. I greatly appreciate you. Thank you so much again for tuning into the podcast. Listen, I'm really excited tonight. Some great things will be said tonight that I believe will be a tremendous blessing to us if we adhere to what's being said. So listen, tonight we have with us every fourth Monday is Keeping It Real with Dr. Denise Gooch. So thank God for Dr. Denise Gooch, radiation oncologist out of Maryland. Thank you so much, Dr. Gooch, for coming on, Keeping It Real with you. What an awesome time we're going to have tonight.
Thank you so much for inviting me. This is always so much fun for me to do this show. And I hope the information that I share is useful to everyone out there, not just the men, but hopefully their partners are hopefully also listening to this, because this is important information for everyone to have. Because as you had previously mentioned, some of the things we're going to talk about is something that couples together can discuss.
Right. Once again, thank you.
As a matter of fact, please
no,
go
sorry,
ahead.
No, I just want to say once again, thank you so much for coming on, and it's going to be an exciting time tonight. Listen, if you're over on Facebook, go ahead and hit the share button. And if you're on YouTube, go ahead and subscribe to the ML Tillery Outreach. I would greatly appreciate it. So listen, let's go ahead, Dr. Gooch, and jump into this conversation tonight about prostate cancer. I know you are a tremendous advocate for prostate cancer, and certainly, you know, I think you a few years ago when I was dealing with it, I called you, you took my call, and you talked to me for about 45 minutes to an hour. So just really appreciative of the information that you gave me, which I was able to make a better decision in terms of my treatment based on what you shared with me. So I'll always certainly just remember those times, that time that you really just poured into me, the educational piece. So thank you again for that.
Well, thank you. It was my pleasure. And as I've mentioned before, that's what I consider the most important part, is for every man to realize he has options. So it's not just one treatment or another treatment, but to listen to all of the options and for a man to make a decision based on what he feels he's most comfortable with. Okay. And one of the things that we have discussed in the past is that, number one, and I talk to men about this all the time, and they sometimes say, well, what did I do? What's wrong? Why am I diagnosed with prostate cancer? Is it because, I don't know, I ate Wendy's a month ago or something? Like, no. Unfortunately, prostate cancer is the most commonly diagnosed cancer in men. And African American men are in particular likely to be diagnosed with prostate cancer. And as a matter of fact, they're almost 6 times more likely to be diagnosed with prostate cancer. And we always talk about, when we think about cancer, we talk about breast cancer, but an African American man is more likely to be diagnosed with prostate cancer than a woman is to be diagnosed with breast cancer. 1 in every 8 women are diagnosed with breast cancer. 1 in every 6 African American men is diagnosed with prostate cancer. So unfortunately, wow, African American men have a higher risk of being diagnosed with prostate cancer.
Wow. So that, I guess that reason alone is enough that we need to make sure that we're getting screened properly and
yes,
getting
sir.
It done.
Absolutely.
Now, what is the age for that? Because a lot of guys say, well, I'm only 40, I'm only 50, I don't need to get screened for prostate cancer. What would you say to that?
Well, as a matter of fact, that's actually an interesting question. For certain types of information, you may see them say starting at age 50, but that's what, as a matter of fact, if you look at the NCCN guidelines, they'll actually say age 50. However, that's for average risk men. You heard what I just said about African American men being considered in the high risk group. So for African American men, my recommendation, and especially the American Urologic Association recommendation, is for African American men to start getting screened at the age of 45. If there is a family history, we're talking about first degree relatives, brothers, fathers, uncles, grandfathers. Actually, the screening should start at age 40. As a matter of fact, I just saw last week a 41-year-old
Wow. 41
who was
years old.
diagnosed with prostate cancer. Yes,
Wow. 41. Wow. That's interesting.
41. And he is so, it was an interesting conversation. He was sitting there, of course, dazed with everything I
Right.
was saying. But he said something so amazing by the time I finished talking to him. He just looked at me. It's almost like what kind of happened with you. Something came over him. He said,
Right.
"So every man should get screened for this." I go, "Yes, sir." And the more he started talking, he went from looking dazed to like almost like he's going to start being one of the strongest advocates. I could just see it in
Right.
his face. He said,
Right.
"There's no excuse if a man can have a 99% 5-year survival, there's no excuse for a man not to be screened for prostate cancer." Just his whole expression changed in the time that I was sitting there talking to him. I told him, "You better watch out. I'm gonna take you along with me while I go and give some of my talks," because yeah,
Yeah.
he was quite inspiring.
Yeah, wow. So listen, if you're on Facebook tonight and if you have any questions, go ahead and put your questions in the comment bar. We should be able to grab them out. And if you're on YouTube, go ahead and do the same thing. And we have somebody monitoring those pages, YouTube and Facebook. So we should be able to get your questions and kind of answer them hopefully tonight. So listen, Dr. Gooch, there are, I did the proton therapy, but what are the treatments for prostate cancer? Are there different treatment that we can get?
Yes, there are multiple different treatments. There's the one that, of course, everyone's heard about, there's surgery, all right? And there's external beam radiation, which is what I do. There's the proton therapy, which is what I recommended that you do. And there's something called brachytherapy, whereas they put the radioactive seeds in the prostate. Some men, depending on how aggressive or high grade the tumor is, we may recommend both in terms of external beam as well as the brachytherapy we call as a boost.
Right.
And now one thing, when I'm talking to men and they're trying to think of their treatment options, I tell them, and this is something I tell men, that if you are, and you can find out if you're considered low risk, it's like cool, medium, or hot. If you're low risk and you're under the age of like 60, I would probably recommend surgery, as to it's probably the cure rate is maybe a little bit better than the external beam radiation. And the reason for that is if it's what they call low grade, and there's some more information we could discuss later. It's a Gleason score, your PSA less than 10, things like that. The chance of the surgery being curative is very high, okay? Now, the radiation's curative too, but it may, especially for the younger patients, give you toxicity that you don't really want to have. Right. Now, for men in the intermediate group, that's when the Gleason score is about 7. Your PSA may be anywhere from 10 to maybe even 20 or even higher. That's what I recommend the radiation. And if you have a higher Gleason's, like 8 to 10, we also recommend the hormone therapy, which is another talk that we can talk about. The thing about it is we can still, as I tell men, the surgery can cure you when you're an early stage. We can cure you even if you're at the intermediate and the high stage. We can still cure you. So some men who don't want surgery, I tell them, sure, that's fine. I can still give you the radiation. We can still cure you. Right. And unfortunately, some men who are maybe at the intermediate stage still got the surgery. Then, and there's something else that we can talk about at a later date, what they call the PSA is, the prostatic specific antigen, the blood test starts rising, because once you have surgery, the PSA is, as I said, it's a protein. It's only made in the prostate. If it starts going up again, that means something is starting to get activated again. And under those circumstances, almost always, then a man is sent to us for the radiation. And recently, we've started doing modalities. So, like they've had surgery, we do the radiation, recommend the hormone. With that, when we have something, it looks like the prostate cancer is coming back. So this is what we call adjuvant therapy. But I have a problem with a man getting trimodality if he didn't need it. If we could have cured him with the radiation, without the hormones, or for the high grade ones, the radiation with the hormones. So then he's gotten basically the side effects of all three things. So that's why I say it's important to get all the information before a man makes a decision as to what type of treatment he wants to have.
Right. Yeah. So I do have a question. So the question is, do you lose inches or length of your penis if you have your prostate removed?
Actually, that's a good question. And
Right.
no, it's true.
Yeah.
And unfortunately, because I also give lectures to residents and medical students at the University of Maryland, and when I was researching the different types of treatments and the side effects and toxicities, the answer to that is actually yes. A man loses up to 2 inches of prostate length with surgery. And when I was trying to get more information, all it says, the reason for that is unknown. But when I asked some of my urology colleagues, they're like, yeah, well, we know that. But the problem is they're not telling them that.
Right.
So
right.
when I give my lectures, as a matter of fact, I gave a lecture about 2 years ago when I was giving at the University of Maryland. And of course, then I'm doing the slides and showing them, all this data and information. When I finished, everyone in the whole audience, I had about 50 people in the audience, were sitting there looking at me like this, like, it's like, yeah, they didn't tell you this part of it, did they?
And listen. This is not your Sunday school class.
Yeah, no, this is your Sunday school class.
This is keeping it real.
This is keeping it real. So, as a matter of fact, when I was giving the talk and I was showing the slides, and I was like, so I can't see. I actually made this comment. I can't see too many men signing up for that. And like I said, the whole time you could just drop a penny throughout the audience as I was talking. I didn't even get any questions. Everybody was sitting there like. So yeah, that's a good question, and that's a real question. And trust me, your urologist won't tell you that.
Yeah, and we need to have these conversations. That's why I'm doing this podcast. We need to have these real conversations, because a lot of men, I have a lot of conversations with different men, and these conversation comes up. We talk about this stuff, but we are afraid, and we're not going to talk about it in church. So we need another platform where we can have these types of conversations, right?
These are because these types of conversations are important. And
they are very
also,
important.
It's very important, and I'm not knocking my urology colleagues, but also men usually have long-term incontinence, which means their inability to control their urine. And now, if you talk to a urologist, they'll say, oh, maybe 5 or 10%. No. The data that I've seen is either 40 to 45% of men have urinary incontinence. And for quite a few of them, it's permanent. And as a matter of fact, most men that I have talked to, and I'm sure you've talked to some men who's had surgery too, that as well as the erectile dysfunction are the issues that they are most miserable about. As a matter of fact, as I said, I do community talks, I talk to churches, things like that. The number 1 and 2 comments that I get from men is that every single last one of them regretted that they had the surgery. I haven't had one yet that said I had the surgery and I'm happy. Every single one stated I regret having the surgery.
Wow. Yeah, I just talked with a young guy. Well, I would say he's young, probably he's 52. So he had his prostate removed. You had that type of surgery. And he was just having a very candid conversation with me, and he was really frustrated because he said, man, I have to see a doctor. I have to do something because I had my prostate removed and my sexual functions are gone. And so he was just really very emotional, stressed out. So this stuff is real. I mean, men, we're not going to talk about it to publicly like this, but it's a real conversation that many men, need to have. We need to have these types of conversations. So I appreciate you being open to that.
Exactly. And it's very important that we keep emphasizing that, because for radiation, we will discuss the toxicity and the possible side effects. But like I said, not knocking my urology colleagues, they tend not to tell men the risk of erectile dysfunction afterwards. All right. And as I said, researching some of the talks that I gave, something that I found interesting is that there's actually some research and some data that has shown that if men are given Cialis or Viagra, I actually have a whole talk on that. The medications actually work, okay?
Right.
But it's when you give them. And actually, a couple of the data, there was actually some researchers from Memorial Sloan that showed that if a man was started on Viagra before his surgery, all right, well, actually, Cialis, I take that back. They, number one, did not lose that length, all right? And number two, they maintained their sexual function after the surgery was performed. And even for me, for when I, before I quote unquote radiate a man's pelvis, no matter what I'm radiating for, whether it's prostate or rectal cancer or anything like that, I always start men on Cialis. Unless there's a medical contraindication, I always start men on Cialis before I start. Because one of the things I want to talk about, like sometimes, just to give a basic overview of men and their functioning and how a man gets an erection. A man needs blood flow and nerve supply. Men kind of instinctively know that. But yeah, you need blood supply and nerve supply. And radiation damages both of those.
Right.
So long term, that's a late effect, erectile dysfunction, maybe not as great as surgery because they damage the nerves, even with the nerve sparing prostatectomy. The nerve sparing, something like 35% of men can't get an erection. You do the regular quote unquote surgery, that's something like 55 to 65%. So basically greater than half. All right.
Wow.
But anyway, so as I said, I start all the men that I take care of on Cialis. I don't do the Viagra. I like Cialis, take one and it lasts all day kind of. I just like that idea. So that's what I start men on before I get started. I keep them on it. And bring it, just to let people know this, to let you know, I will actually prescribe it. Something like 50% of men's insurance companies won't pay for it. That's something else I found out. Unless they're 65 and over. For some reason, Medicare will pay, but the regular commercial insurance tends not to pay for it. But some of those online forums, I have at least 3 men right now that have gotten their medicine from HIMS. Someone, matter of fact, I just talked to someone and they said, HIMS, they said, I thought that was fake. I said, no, it's real. I've got about 3 of the men that I'm currently treating for prostate cancer that take it, and they actually can get it from HIMS. And it's a little less expensive, something like $5 a pill, something like that. But just to let you know.
So I have a couple of questions over here on YouTube and Facebook. One of the questions, let's see, why do they generally stop screening at the age of 70?
Well, yeah. That's actually an interesting question. We actually think about that also for breast cancer. I guess the reason is we're talking about, 99% 5-year survival, 90% 10-year survival, quote unquote. So I guess once a man hits the age of 70, if you look at the actuarial tables, I guess they're not expecting you to live beyond 10 years or even maybe to 75. Not that I think that's a good idea, but I think, especially as a man and a woman for that matter, gets older, you're more likely to maybe have other medical conditions. And that's something else that even the NCCN guidelines state. If a man has other conditions, that maybe he's had a stroke or he has out of control diabetes or something else, that the prostate cancer may not be the predominant issue to take care of. But I will tell you right now, I am currently treating at least 6 men over the age of 70 because I don't, same thing for women. I mean, I don't limit it based on age or something like that. So yeah, if a man gets pushed back from his doctor, one thing about, at least here, LabCorp, I don't know if this is an aside, you can pay for your own labs if you want. You just, if you have LabCorp in your area, and you can just sign up for it. So you can get your own PSA check. And if it's elevated, of course, then that's what we call advocating for yourself. And then you can advocate, say, okay, well, send me to a urologist. You see, and then you take those steps 1, 2, 3, 4, the same way you would if you were 55.
Yeah. So back over here, we're getting a lot of questions tonight. So what would you say some of the biggest challenges with men getting screened?
Yes.
So what do you think some of those challenges are in terms of men? Yeah, a lot of men are afraid of the DRE, right?
Well, I'll be honest with you. Okay, that's something else I talk about. Men are allegedly, I'm going to be honest with you, men are allegedly afraid of the DRE. All right. Now, whenever I've given talks and all the men look at me, and I'll be honest with you, that's something I still do.
Right.
I do digital rectal exam, but I tell men that they don't have a person, especially if they know what they're doing, it should not be, other than a little uncomfortable, it shouldn't be painful.
Right.
Because when I do it, I'm just trying to examine the size of your prostate. As a matter of fact, some of the newest guidelines don't even recommend a DRE. Basically, and I've been asked by some of my people that I know, like, why do they no longer recommend the DRE? And I say, well, I'll be honest with you, a lot of primary care doctors, it's not that they don't know what they're feeling, but they don't have an appreciation for what they're feeling. Radiation oncologists, urologists, we know what we're feeling because we're trying to assess the size of the prostate and we're trying to assess the firmness of the prostate. And you can actually get a lot of information from that. Right. But like you said, no one should, I mean, it really shouldn't be that uncomfortable. Right. And the other theory that I have, I mean, they say that men are afraid of the DRE. I tell people, I don't think men are afraid of the DRE. I really don't. I think men are afraid of us finding something and then recommending they get worked up for prostate cancer, and because they don't want the risk of erectile dysfunction.
Yeah, that was my fear. It wasn't. I mean, I didn't. I mean, it wasn't like I was excited for it, but
no, exactly.
But my fear was, are they going to find something, right?
Exactly. That's what I think. And every time I've given a talk, and I say that. As a matter of fact, once I was giving a talk, I was in Atlanta. It was so funny. And I was talking about all this. The guy who was supposed to be recording stopped recording, or he put it on automatic, came from behind his, his video and all that he's recording to stand in and watch the slides and everything that I was doing. I just saw him go. He was more interested in my talk than he was. And he kind of, I guess, put all his recording on automatic. Because, as I said, just from the years I've been doing this, the men that I've met, they're more concerned about, if, as a matter of fact, and some of the urologists admit this too, if I say I don't want the DRE, then I don't have to get the workup, then they won't find anything, blah, blah, blah. But then unfortunately, like we said, it's the number one diagnosed cancer in men. It's the number 2 cause of death for men. Wow. Okay. Number 2. And I tell men, no, we don't want anybody dying from something that we can pretty much cure.
Right.
Like I said, prostate cancer, and I tell them, this is what I do all day. Okay, I treat cancer. Prostate cancer has the highest cure rate of all the cancers I treat. I mean, I could line up 100 people. Wow. If whatever percentage of them have prostate cancer and it has not spread, even if it's advanced maybe to those regional lymph nodes, as long as it's just still local regional, I still have a better chance of curing you than the woman who has probably an early stage breast cancer. I mean, that's just how high the cure rate is. Wow.
Powerful stuff. So let's see here. I'm having a lot of questions. This person says they had a biopsy in 2 areas. I guess 2 areas came back positive for cancer, but then 3 areas were suspicious. What that word suspicious? What are they saying with that?
Okay, then that's an excellent question. The prostate is a gland. I tell people, think of it as an orange, all right? Even though that's, So let's say there's some bacteria hiding in that orange, all right? So you take a needle and you start sticking it in that orange. Now, there's a chance you may grab that bacteria that's in there, but there's or you may get like some of the bacteria that, like the shell of the bacteria. So that'd be the suspicious part. Like maybe there's something, but we don't have the meat of it.
Gotcha.
But think about all those other areas where you have totally missed the bacteria. It doesn't mean it's not in there. It just means you missed it. All right.
Right.
So, and there actually, I keep talking about studies, and because like I said, I have to when I give lectures to residents and medical students, that even men who maybe only had 1 or 2 biopsy cores positive, when they take them to surgery, pretty much 60% of them are upstaged, which means that there was more disease in their prostate. And I'm sure you've talked to men and they found that to be true than what they initially thought with the initial biopsies. As a matter of fact, for a man with, they may just have Gleason's 6, all right, as I just mentioned. and they go to surgery, 30 to 40, sometimes up to 50% of those men will actually have Gleason 7 in the actual, when they actually take out that prostate and look at it under the microscope.
Wow. Wow.
So there, yeah. So thinking that, okay, I'm comfortable, there was only 2 biopsy cores positive, that very well is like the Titanic. That's probably the tip of the iceberg, unfortunately, especially an African American man. You don't want to take that chance. I used to work in this clinic that I had a draw sheet that I could draw. And I would tell people, I said, you know what? I want you to stay on this side of the draw sheet, okay? Because I can talk to you about cure rate, percentages, you living on, you walk your daughter down the aisle, you see your first grandbaby being born. That's where I want to keep you, okay?
Right.
If you decide to do that active surveillance, which everybody who knows me knows I hate, and all these other things, by the time, unfortunately, they diagnose the invasive prostate cancer, it may have spread. See, then you're on this side of the drape. See, then
Right.
I got a different conversation for you.
Right.
And I say that, and I actually saw a lady like about a week after that she was exactly in that position. And she just looked at me. She said, you warned me. I go, yes, I did.
Wow. Wow.
Yes, I did.
Yeah, they kind of recommended that for me, but after talking to you, I knew that was that wasn't even an option, right?
Exactly. And that's something else that it really bugs me whenever I go to a conference myself and I'm listening to someone talk. And someone may say, well, the uniform health services was saying that, they're over screening of men with prostate cancer and that they should not be screened as often and things like that. And I will actually raise my hand, which makes everyone nervous because if I raise my hand, I'm coming for you. I'm coming for you. And I actually I said, what you need to do is read the entire thing that the NCCN guidelines says, not just a summary.
Right.
Because what the entire portion of that states is that when you look at different risk groups, there are certain men that can be considered low risk, but that is a heterogeneous group. And you cannot just group them all together because a man may have Gleason's 6, but if it's in more than 3 biopsy cores, and if he has a family history, and if it has a high velocity rate, and if he has a high PSA, those are the men that need to be treated because they are more likely to have more aggressive disease. And remember I told you about that orange in biopsy?
Right, exactly.
So, just because that's all you got in the biopsy doesn't mean that's all that's there.
Right, right. Wow.
That's why it's important for people to advocate for themselves. And I tell them, if your primary care doctor tell you that, tell them to read the whole part of NCCN guidelines and tell them I said so. Don't just read the summary.
Yeah. So I have a question. Sure. When we look at disparities with blacks in terms of getting proper care that we need, so I think that you can let me know, but is that one of the things that kind of adds to that percentage in terms of us not getting the treatment or the options for treatment that our counterparts get?
Well, that's a good point. There's a lot of what you want to call systemic racism, cultural bias. There's a lot of some of that out there, even for physicians. If they may say they don't have it, they still can be found that way, which is why it's so important that men, because women will advocate for themselves. Let me make that very clear.
Right.
So that's why it's so important for African American men to advocate for themselves. All right. Now, I told you that I have quite a few men over the age of 70 that I'm treating. And I will be honest with you, at least a third of them, that was their first PSA test.
Wow.
And that is totally unacceptable. So, being in your 70s, getting your first PSA and finding out it's 35, no, that should, no. I was actually quite impressed with my 41-year-old because I actually asked him, so what made your family doctor check your PSA? I mean, I'm glad he did. He didn't have a
Right.
strong family history. He had an uncle, but ironically, his father didn't have it. And perhaps his grandfather, there was some question about the grandfather. But I was quite impressed that his primary care doctor still checked it. So now, and it was really interesting, and I just thought about this as I'm talking, this patient has a twin. And so now I didn't, as I was doing his consult, I was like, oh, I need to mention that he has a twin.
Wow.
So the referring doctor, I asked him to potentially do some genetic testing because I'm jumping ahead a little bit, but they're actually beginning to notice, just like for women, that some of the breast cancers can have a genetic basis. Certain men's prostate cancer certain men may have that BRCA, that breast cancer. It's a tumor suppressor gene. And especially men with the high grade prostate cancers, they're starting to notice that they actually carry that gene also. So if a man has a sister or someone like that was diagnosed with breast cancer, and if she tells you that she has that BRCA, especially the BRCA2 gene,
Right.
then he should definitely get screened for prostate cancer. They're actually showing a connection between that.
Wow. Wow. So there's someone over there on Facebook. What are the symptoms of prostate cancer? Well, I can tell you. Then I had no symptoms at all. So go ahead, Dr. Gooch.
No, what you said is 100% true. For 90+% of men, there won't be symptoms. As a matter of fact, by the time a man gets symptoms, unfortunately, it's usually more advanced. To give you an overview, men, and every man's listening to this knows it's true. As a man gets older, okay, his prostate will enlarge. That's called BPH, benign prostatic hypertrophy. All right, so it just increases in size. And the anatomy of a man, his bladder, which is why, the prostate's at the base of the bladder. And so to empty his bladder, it has to go through the prostate. So if that prostate is getting big, it's actually the urethra, of course, drains the bladder. So he's getting the urge to go more often and maybe go more frequently as he gets older. That's a natural occurrence that happens with men. So the only thing a man may notice, and I'd say at least 50 to 60% of men notice this, is the urinary, the BPH symptoms, the urge to go more often, a feeling like he doesn't really empty his bladder, but that's just a normal process that every man will go through, with age.
Right.
So that's not so by the time a man notices symptoms, quote unquote, unfortunately, it would be something like pain. That's not a good symptom. That's more likely that it's already spread.
Right.
And that's when we're in that other part of the category that, I can't quote those 90 to 99%
Right.
cure rates.
Right. Wow. That's why the screening is so important, right?
That's what screening means. You screen when you don't have that. The definition of screening is to actually be checked before you have symptoms. All right. You want to be checked before just like for women, they get mammograms, not when they feel, you can get one when you feel something, but not when you feel something, but before you feel something, before something's palpated, so you can be diagnosed, treated, and cured at an early stage. Same thing for men. And remember, African-American men are more likely to be diagnosed with prostate cancer than women to be diagnosed with breast cancer.
Wow. So we're going to pull one more question. Are there any cases where active surveillance is a viable option?
Well, I'm just going to quote the American Cancer Society, all right, that they recommended if a man maybe is not, quote unquote, ready to move forward with treatment, all right, and active surveillance means active, all right, so it doesn't mean, and I talked to other doctors because this came up in a session once, and the doctor was challenging me, and I was like, yes, but that doesn't mean that you just leave him alone and bring him back in 2 years. And he gave me this funny look. And then I knew something happened. So what happened? By the time he brought him back in 2 years, of course, his PSA had doubled. So active surveillance means that there is surveillance going on. A man is getting a PSA checked every 6 months, all right? If there is a change in the PSA, which means that maybe he hasn't seen a urologist, once if it's 6, once it gets to 8, all right, then the staging actually is 10 and lower. So if it gets to 8, then that means that it needs to be evaluated. All right. Now, if it's at 6 and it stays at 6, then maybe wait another 6 months. You see, but this active surveillance. But the important thing, according to American Cancer Society, is that treatment should be initiated once those parameters change. All right.
Wow.
So whatever the screening baseline is, once that changes, and it's important to get that, and it's a blood test. Matter of fact, I tell men they're fortunate they have a blood test that actually, as I said, is a protein only made in the prostate. So you can just get a blood test, see what that PSA is. It's important to maybe get it done at the same lab too, because different labs have different chemicals. So one may make it seem more elevated than the other.
Right.
But yes, if a man does opt for active surveillance, it has to be active surveillance. All right.
Wow.
Don't get it, like I said, once and then 2 years later, because you're not going to like what you see.
Right. Wow. So we're going to pull one more question off Facebook, YouTube, and then we're going to allow you to close it.
Sure.
Explain the TURP procedure. Are there negative after effects, and any idea of the success rate of that procedure?
Okay, transurethral radical. Usually that's when they do the prostate biopsies, okay, because it's a little different than when they actually do the surgery to remove your prostate. So I'm not a surgeon, but I just know the journal process of that. Of course, it's surgery, so it's important to know that. And oftentimes, what will happen is a man probably has that BPH symptoms that I said. So more than likely, he's already having urinary symptoms. So one of the things that sometimes surgeons will do is something called what they call roto-rooter. You kind of core out the prostate to take the pressure off the urethra so a man can urinate better. But at the same time that they're doing that, they'll also biopsy the prostate to make sure that the reason for this enlargement of the prostate is, quote unquote, just a benign prostate, and prostate getting bigger as a man ages versus prostate cancer. So it's a surgical procedure that a man will undergo to, number one, as I said, to relieve his symptoms of BPH, to help him urinate better, but also at the same time, as I said, the urologist can do prostate biopsies.
Wow.
To biopsy his prostate.
Wow. So is there anything else tonight that you want to share in terms of prostate cancer or men's health?
Okay. It's funny you mention that. Yes, I do. Something we were talking about before we came on air. My personal feeling is that we don't talk about men's health enough. Right. We talk about women's health. I mean, as you know, you turn on the TV, you go to 4 different stations or whatever, HBO, CNN, whatever. We talk about women's health. We don't talk about men's health. And I think that's something that's not talked about enough. As you said, you talk to men. My very good friend and colleague, Professor William Battle, he has a prostate cancer support group for men, because men need a place where they can be themselves and open up and be vulnerable. I mean, right. Men have feelings too.
Right.
And I think for a man to feel like he always has to be strong, he can't share his feelings. There's no safe place for him to be to express his feelings.
Right.
That's where you get all this anger, all this PTSD, all this depression.
Right.
That no one talks about. And then, I mean, I hate to say some of it, then they go around and start shooting up, a whole grocery store, something like that. I mean, I'm not saying that that's related, but
right.
I think there's a lot of unaddressed anger and frustration out there, that there is no area that a man can feel safe and comfortable expressing himself or getting support if he realizes that he has an issue or that there's something that he wants to share. Who is he going to share it with? I remember once I was giving a talk to the medical students, and I actually showed them a picture. Now, when women get together, it sounds funny, but it's kind of interesting. We tend to go and we'll be in a circle. So we face each other, right? And as we know, women very seldom together, and you've seen this. Like for sports night, all men sit in a row. All right. So they're lying beside each other, but men won't go into a circle facing each other and actually kind of sharing that space and that energy that that women will do. All right.
Right.
So you may have 6 men all lined up beside each other.
Right.
But an opportunity for maybe someone to say, yeah, man, have you gotten your PSA checked? Or, yeah, man, I'm starting to have symptoms, or I'm having issues with erectile dysfunction. Has anyone else had that? Now, what do you think the chances of that kind of conversation happening?
Very slim.
It's very slim. That's just not going to happen. That's what I want to close. It's not going to happen. Okay.
Right.
That's why I think there needs to be a different mindset, so that's something that men should be able to do, be comfortable with, because anyone who has been in a group, and me, as a physician, all it takes is one person, what I call one brave soul, to break the ice and blurt it out, and then it just kind of pours. When it rains, it pours, and I mean, all this comes out.
Right.
And you're like, oh, so a lot of people have been thinking and holding it all in until one brave soul speaks up and says something.
Wow. You're exactly right.
Wow.
Yeah. So listen, this has really been a great conversation tonight. Now, next month, Dr. Gooch will be back on 4th Monday of each month, keeping it real with Dr. Gooch. Listen, can we really get into this ED, erectile dysfunction, next month?
Yes, I definitely want to discuss that, because I know it's an issue for men. As I said, they're definitely not going to sit around with a group of men to talk about. But it's important to know that there are ways to address it. There are ways to treat it. And probably something a lot of men are interested in, maybe ways to avoid it.
Right.
To lessen your chance of having it. Or if you have it, ways to actually improve it, or improve your ability to have an erection and get sustained sexual activity. So yes, we can definitely talk about that.
So you heard it, man. Next month, 4th Monday of September, we're going to be. So make sure you get your buddies on. Let's have this conversation.
That's right.
Once again, keeping it real with Dr. Gooch. This is not Bible study or Sunday school, so we need to have these conversations. Sometimes they may be uncomfortable, but they are very much needed.
Absolutely. Thank you for giving us this kind of platform to be able to discuss these critical and important topics.
Thank you for coming on and just being a part of it and sharing with us. I really greatly appreciate it.
My pleasure.
Well, listen, guys, this has been an awesome time tonight. We pray that you got something, and I'm sure you did. I got something out of it. Great information. If you're over on Facebook, I would greatly appreciate it if you could go ahead and hit the share button. Just hit the like and share. I would greatly appreciate that if you're over on Facebook. Go ahead and hit that share button. And if you're over on YouTube, and some of you were over there, had quite a crowd over there tonight on YouTube, go ahead and subscribe to the ML Tillery Outreach. And to those of you that's listening via the podcast channels, we greatly appreciate you. Thank you so much for downloading our podcast, Advancing the Kingdom podcast. It has been a tremendous blessing. So we greatly appreciate you as well. Once again, we have been keeping it real with Dr. Denise Gooch tonight. Thank you again, Dr. Gooch, for coming on the podcast.
My pleasure. Thank you for having me. This is fun. I look forward to next month.
Amen. So listen, next month, Dr. Gooch will be back 4th Monday. I can't remember what that date is, but she will be back 4th Monday. She's going to be talking about ED, erectile dysfunction. So listen, I am Matt Tillery. It's been a great night. I greatly appreciate you. Until next Monday at 7 p.m. Go and advance the kingdom.
We pray you have been empowered and blessed by this teaching. Join us next week for the Advancing the Kingdom podcast. If you would like to reach us, email us at mltillery@icloud.com.